Really? Wow. That much. That's great. So fun. For the Excel. For Excel, quality. Let's start.
Very good morning to all of you and those who are present here as well as joined online. And we have a very timely topic today, management of COVID-19 pneumonia by an eminent sort of, doctor who is involved with COVID management of COVID patients, Dr. Amila Rathnapala, who is a consultant respiratory physician attached to National Hospital Kandy. And I also would like to thank Dr. Anuma Siribardana, who initiated this and organized this. And I'm happy to say that she promised to have series of lectures on this in the coming weeks. So without taking much time, I would like to invite Dr. Amila Rathnapala to continue with his lecture, COVID-19 management of COVID-19 pneumonia. Thank you.
Thank you so much. And first of all, I'd like to thank for the KSM for providing me this opportunity. Yeah, I mean, COVID is a day-to-day issue now, and we are facing an outbreak in Sri Lanka. Now it's a global pandemic with multiple variants, and we are seeing new syndromes associated with COVID-19. So we thought of discussing predominantly about COVID-19 pneumonia. So that is one of the major health hazard that we are facing for the time being. So COVID-19 is an evolving situation and it is emerging and rapidly evolving. So therefore, we should be really updated regarding the situation because the syndromes that we see could differ from day to day. And today I'm going to discuss about the overview as well as the disease categories and therapeutic management, as well as discuss about post-COVID syndromes. And furthermore, there's with the COVID pandemic, there's an information pandemic as well. There's a lot of misinformation as well as disinformation is circulating. So therefore, you should clearly refer to the scientific knowledge which is presented in scientific journals as well as in other reviews and things like that, rather than referring to various social media and things. So therefore, whenever you come across the information, please classify whether it is a misinformation or disinformation, or whether it is coming from a classified source. And so there are few management principles. If you get the disease process, there are two disease processes that we can discuss. One is the early phase disease process, where there's significant viremia, and then the late phase disease process, which is driven by the inflammation, host inflammation. So as an initial assessment, it is very important to get the history correct, because the disease phases and the severity, everything we can assess through the history. So therefore, we have to ask about the onset of the symptoms. I think most of the clinicians, they are discussing about the date of PCR or date of rat positivity, but that is immaterial. The most important thing is that you have to ask the symptom onset, when the patient develops fever, when the patient develops sore throat. So that is the day one of the disease. So from there onwards, we are calculating the disease. So therefore, PCR positivity date or rat positivity date is immaterial. We have to ask about the symptom onset date. And then you have to ask about the red flag symptoms always. For example, we are more discussing about the kind of cough and loss of kind of smell and everything, but there are red flag symptoms that you have to ask whether these symptoms are present. Number one is the breathlessness. So breathlessness, if the patient is breathless at rest, yes, that is significant. Or it could be exertional, post-exertional breathlessness. You have to ask about this. And then the chest pain, that is also very important, and faintness or syncope. When examining these patients, you have to ask about the, you have to examine the respiratory rate, that is very important, and saturation at rest. Not only the saturation at rest, and if the patient saturation is more than 96 at rest, you have to exert the patient and see whether the patient is desaturating on exertion. I'll discuss about that. And then you have to auscultate the lungs to see whether there's any auscultatory findings, predominantly the fine crepitations that we hear. Sometimes added sounds like wheezing and bronchi could be audible. So this post-exertional desaturation has been standardized actually. It is, there are studies coming through that even the patients are not desaturating at rest. If they are having exertional desaturating, that is one of the important prognostic markers. So when you see mildly symptomatic or asymptomatic patients, if their saturation is more than 96 at rest, and if they can stand unaided, so these are the patients that you should walk for 2 minutes and see whether they are desaturating. If their saturation is dropping more than 4%, that is significant that there is a bad prognosis. The patient can deteriorate very fast. So there are 4 steps that you should kind of assess whenever a patient is coming to you with COVID. So first, you have to initially stabilize the patient. Patient might be very, you know that with the COVID diagnosis, patient is anxious anyway. Therefore, patients are breathless. They are sweating. They are having palpitations because of anxiety. And most of the patients with fever and febrile illnesses, they are actually having dehydration. So these patients are tachycardic and tachypneic. And so based on that, if you are assessing the disease severity, you are falsely assessing the severity. So therefore, first step, whenever patient comes to you, first you have to reassure the patient, okay, we know your diagnosis and we are here to treat you. And you have to reduce the patient anxiety. And then stabilize the patient, your airway, breathing, circulation, and disability assessment and exposure evaluation. So this ABCD approach, you have to see whether the patient's airway is all right, because some patients, they might have a lot of secretions, and then assess the oxygenation, and then assess the breathing as well as circulation, the blood pressure and pulse rate, and then assess the disabilities, especially when the patient is confused or not, disoriented or not, and then assess the electrolytes as well as the random blood sugar. So initial stabilization using this is a ABCD. I mean, every clinician knows about this ABCD approach. So whenever a patient comes to you, don't jump to say this patient is having severe disease, but just to stabilize, make sure the patient is not anxious, and make sure the patient is not dehydrated. So after stabilizing, the next step is to assess the disease severity. So it could be mild, moderate, severe. However, if the patient does not require oxygen and his patient's saturation is more than 96% and the patient's respiratory rate is less than 90, and if the patient does not need any organ support and blood pressure is stable even after fluid resuscitation, so in that case, we can consider these patients are having mild. If the patient is requiring oxygen, For example, if the saturation is less than 94% at rest, or if the patient is when the patient is exerting their self and saturation drops to 4%, that is less than 92%. In that case, remember that this patient is saying moderate disease. And if the patient is requiring oxygen to maintain their saturation more than 94%, through without any high flow devices or any NIV, with simple oxygen supply, that we can consider that as a moderate disease. And with patient requiring high flow devices, with patient requiring non-invasive ventilation or mechanical ventilation, in that case, we consider this patient having severe COVID disease based on their oxygen requirement. The third step is that we have to assess the disease stage. This is very important. I think most of us, we are managing with various drugs. I think, I have seen several patients who have been using steroids by themselves, especially the medical professionals, doctors and nurses. They are using steroid at home. This is really harmful. So you should identify the disease stage. The first, you should know the symptom onset date, that is the date of symptom onset, that is not the date of PCR or the RAT. And then from there onwards, there are three phases that you should identify in COVID. The stage 1 is the viremic stage. And viremic stage usually lasts about 5 to 7 days. And then patient is coming to the pulmonary phase, that is stage 2. And there are two phases for the pulmonary phase, that is stage 2A and 2B. 2A, you have radiological abnormalities, but patient is not hypoxic. Patient is fairly all right. Patient is sitting and without any hypoxia, but X-ray there are so many shadows. And the phase 2B is hypoxic phase. There is also there are radiological abnormalities, and the patients are hypoxic. And then the stage 3 is your hyperinflammation state, where the host responses have started. So basically, about 5 to 7 days time, you have the viremia, and then next 5 to 7 days, up to about 14 days, you have this pulmonary phase, and then after 14 days, 14 to 21 days, that we are experiencing this hyperimmune state or host immune response. If you get a survivor, and so this is the stage 5 survival. If you get a survivability, if the patient is progressing to this stage 3, you can see here that patient's survival is going down. If the patient is going to the hyperinflammation stage or stage 3, usually their survival is full. And viral load drastically come down after 2 weeks. And there's basically at stage 3 or your hyperinflammation stage, there are no viruses in your circulation, and inflammation is progressively going down. So remember, it is very important to identify these stages before you treat, because if you treat with immunosuppression at the viremic stage, you are going to lose the patient. And if you start various kind of any other immunosuppression, but be very careful. So therefore, I'm strongly discouraging the home-based steroid therapy for patients with COVID. I think I know most of the patients I have seen, they have taken steroids at home. Whenever they have diagnosis of COVID, they have started using steroids. So that is extremely harmful, and you should not do that. And please give this message to everybody. Never use steroids without a clinical assessment. And then at about 10 to 14 days, the phase stage 2, that your antibodies are usually becoming positive, IgM and IgG. So in that case, actually you can consider these patients, their infectivity goes very low. So in the most of the time, our experience, patients are dying at stage 3. I think you might see some patients, they are in the intermediate units and observed for 14 days, and about 21 days, they are coming and they are dying at the ET. So we see these scenarios because the hyperinflammation stage is the disastrous stage that we have to prevent. So then the first step is you have to identify the disease onset, and the second stage is assess the disease severity, and third is assess the disease stage, and the fourth is identifying the high risk group. So if the patients are elderly and there are comorbid conditions, any comorbidity, it could be respiratory, diabetes, ischemic heart disease, obesity, they are having a high risk. But from the data that we have, we know diabetes is the number one high risk factor, as well as obesity. They are having a very high mortality. And then immunosuppression. If the patient is on any sort of immunosuppression, this initial viremic phase will be handled very poorly. So therefore, these patients are having a high risk of mortality. And then the pregnancy is also a high risk factor because they are in a basically immune suppressed state. So I'm going to discuss about the management based on the severity and the stage. Remember, this severity and stage is very important. So whenever you're offering treatment, you should know what is the stage as well as severity. Right. The first stage is a mild disease where the patient are not hospitalized and patient do not require any supplemental oxygen. These are the mild patients. I think most of the intermediate centers that we have managing patients of this sort. So what is the objective of managing these patients? The objective is that you have to prevent these patients getting to the next stage. That means that you have to prevent the progression of the disease. You have to prevent these patients are progressing to the disease. So all the interventions that we are going to do at this stage is to prevent their disease progression. That means that you should prevent going to the next stage of oxygen requirement. How do you do that? Again, we are talking about this viremic phase. So most of the patients that we are talking about in the viremic phase. So how do you diagnose viremic phase? The viremic phase clinically manifests as within the first week. They are having fever, they are having cough, and the classical investigation in their counts is they are having severe lymphopenia. We are measuring as neutrophil to lymphocyte ratio. If the neutrophil to lymphocyte ratio is more than 10, they are having a lymphopenia. And this, if the lymphopenia is persistent, we know that there's significant viremia is going on. I mean, we are seeing patients, especially diabetes and immunosuppression, this viremic phase is going up to about 21 days and sometimes about 24 days. And if you can observe really well. Actually, if you do the counts, their lymphocytes are usually less than 1,000, and some patients may be less than 500. So you might see that in 7 days' time this will be over, but in certain patients, especially diabetes and immunosuppression, this viremic phase will be going for about 3 to 4 weeks, and then their lymphocyte will be persistently low. So that is the indicator or biomarker of this stage 1 disease. And what is the biomarker of stage 2? That is imaging, radiological imaging, either X-ray or HRCT. At the phase 2A, that is when the patient is not hypoxic, usually X-rays are normal, but if you do HRCT, there are HRCT classical features of we can diagnose COVID at that stage. And if you come to stage 2B, when you're hypoxic, usually you see the X-ray bilateral radiopathic patients of the lung. And then when you come to the stage 3, so what are the stage 3 biomarkers? CRP. These are the acute phase proteins. The CRP or C-reactive protein, serum ferritin are the basic biomarkers of this stage. So remember, now we are talking about disease. At the initial stage, our biomarker is lymphocyte count, that is neutrophil to lymphocyte ratio. At the stage 2, we are talking about the imaging. Stage 3, we are talking about the acute inflammatory proteins, that is CRP and ferritin basically. Right, so what are the disease-specific therapies that we have to offer at the mild disease, that is stage 1? So if the patient is with you, and if the patient is having high risk factors for progression, for example, patient is having diabetes, obesity, or any other risk factors, there are treatment in the world, but not in Sri Lanka, unfortunately, to prevent this disease progression. These are the monoclonal antibodies. There are two classes of monoclonal antibodies, that is this belanimab and estemimab, as well as casirivimab and imedimab. So there are phase 3 clinical trials has been done, and these are effective at the viremic phase. So we are quite unfortunate that we don't have. I mean, because if there's a high risk patient or pregnant patient or whatever, we can use this monoclonal antibodies and we can prevent the disease progression then and there. At the viremic phase, you stop the progression. That's all. But we are quite unfortunate we don't have them. And the main drawback or main issue with these monoclonal antibodies are that, especially when you have this mutant or variant, especially the E284 variant, which is present in India for the time being, and it can evade this monoclonal antibodies and bypass this. But that is the single variant or Indian variant, that which can bypass this, but all other wild type as well as the UK variant are sensitive to these antibodies. And then remdesivir, which is an antiviral agent which has been originally used for Ebola, which could be beneficial at this stage to prevent disease progression. And remember, immunosuppression, so dexamethasone or any steroid or any biological agent at this stage when the patient is having viremia is extremely harmful, which can result in mortality. So this is a mutation that we are talking about that is called VOC or variant of concern, which is detected in India. E284 mutation of the spike protein, which can evade, which can bypass the antibody response of the host. Right, and then antithrombotic therapy. At a mild disease, we do not have any evidence for antithrombotic diseases therapies. Basically, there's no indication for screening as well as no indication to commence antithrombotic therapies at this stage unless the patient is already on antithrombotic therapy. But if you ask from the patients that I mean, most of the health professionals that they are taking aspirin at this stage, but that is, we don't have any evidence for that. And also that for the time being, we know that it could be harmful, but we don't have any evidence for that. But I think I'm strongly discouraging using aspirin at this stage because we don't know the exact mechanisms of the virus still. For the time being, there's no evidence of protecting you by using aspirin. So the usual combination these people are taking, methylprednisolone, aspirin, azathioprine, and kefirone. So these are the things you should avoid. And vitamin C, vitamin D, and zinc. Again, there are observational studies that when you supplement with these vitamins, their outcome will be better. But these, remember, there are no RCTs, randomized control trials, but there are a lot of cohort and observational studies. They found that patients who improved had a kind of this vitamin supplementation has improved them. But again, we don't have strong data, but it doesn't do any harm. But when you have a patient with acidosis, or when you are looking for, especially the ICU care, we have seen actually some patients are acidotic and we don't know what is the cause, and patients are having high anion gap acidosis. We are looking for everything LDH normal, keto acids are normal, and this ascorbic acid could be causing this. So therefore, is vitamin C. So therefore, don't use as a blanket therapy. When it is causing harm, just withdraw them. Because we had cases like that. Patients are having metabolic acidosis, and sometimes when you withdraw this ascorbic acid, the metabolic acidosis is resolved. And then the next step, that is the patients who are hospitalized and requiring supplemental oxygen only. Again, this is at the early stage of stage 2. And again, our objective of our treatment is to prevent disease progression to the next stage. Again, we are talking about this stage, stage 2B, where the patients are hypoxic and the patients have the early pulmonary phase of the disease. That means that they are having a viremic response and they are having overlapping of viremic response versus immune overlapping. So there's an overlap. So there's viremia is going on and there's host inflammation is also going on. So both are there. Again, at this stage, you have to be really careful when you are going high dose immunosuppression. So the drugs, again, we don't have remdesivir for the time being. That has been approved and proved in ACCT1 trial, which has been not proven in other trials. But however, the remdesivir has been approved to use at this stage. And the patients are hypoxic at the early stage when you're only requiring supplemental oxygen without any advanced devices. And the next option is to go for remdesivir as well as dexamethasone combination. As I said, there's a viremic response and there's a host immune response. So they have to blunt them both. So ideal is that is most of the panelists, in expert panelists, they're using this combination, remdesivir versus dexamethasone. They're combined together at this stage 3. But again, we don't have remdesivir. We can use dexamethasone, but remember that we are using the 6 milligram dose. We should not use the high dose dexamethasone at this stage. Especially the methylprednisolone pulsing, 500 1 gram pulsing is extremely harmful at this stage. Again, we can assess the coagulatory parameters at this stage. And again, if there are significant elevation of the D dimers and things like that, you can consider starting therapeutic anticoagulation. But however, now we have evidence all these patients who are having hypoxia, and it is we have evidence to recommend them anticoagulation prophylaxis or thrombotic prophylaxis. That is your enoxaparin 40 milligram daily on them, because we know that with this host immune response, they are having a high risk of thrombosis too. And yeah, whenever you are suspecting thrombosis, you should go for imaging and confirm it, either CTPA or any sort of imaging. And if you can't do the imaging, if the patients are critically ill, you might do the D-dimers. And if there are more than 1,000, you can upscale or escalate your enoxaparin or your anticoagulation to the therapeutic level. Otherwise, all the hypoxic patients actually who are having COVID pneumonia, now the recommendation is to consider starting VT prophylaxis with anticoagulation. Again, this supplementation you may consider or may not consider depending on the case by case basis. But remember, these are not uniform or practices that you can decide on the patient and then continue. And the next stage is hospitalized patients who require delivery of oxygen through high flow devices through or through NIV, non-invasive ventilation, or bilateral. Remember that what is our aim of this management is to prevent intubation at any cost. Why you are preventing intubation? What do you think? What is the mortality of intubation? And we are having a COVID ICU and with intubating facilities. Anybody aware of our outcome? Yeah, it's closer to 100%, right? All the patients, about more than 95, our mortality is there. So that means if you intubate a patient, that we know that patient is dying. I might not be the disease itself, but there are so many issues, confounding factors. But still, the outcome is intubation equals death for the present in Sri Lanka. Therefore, we have to prevent intubation at any cost. So you have to use all the methods to prevent intubating these patients. So therefore, you can see the high dependency units are the ideal setups for the patients with COVID rather than the ICUs per se. Again, we are talking about this stage, the stage 3. So when the patient requiring high flow devices or non-invasive ventilation, they are at this hyperinflammatory stage. The host inflammation is very high. And again, what are the biomarkers? Your CRP, ferritin, and the LDH. These are the biomarkers. So what are the drugs that we can use? Okay, we have dexamethasone IV 6 milligram for 10 days. We have a major trial. There's recovery trial has been proven. There's a mortality benefit when you start dexamethasone 6 milligram. And then some people they are using combination of dexamethasone and remdesivir, especially if the patients are lymphopenic at this stage. If the patient's lymphocyte count is not improving at this stage, there are some experts that are using combination of remdesivir at this stage. However, if the patient is requiring oxygen, or if the oxygen requirement of the patient is going rapidly, within 24 hours, for example, you have to step upscale patient's oxygen level from supplementary oxygen to high flow devices. That means there is significant oxygen requirement within a short period of time, which has been proven with abnormal shadowing of the X-ray as well as high inflammation evidenced by CRP. We usually take either CRP doubling within 24 hours or CRP more than 75. That is an indicator for biological therapy. So for the time being, in Sri Lanka, we have tocilizumab, which is an IL-6 inhibitor. But remember, whenever you are using IL-6, it should be a multidisciplinary discussion and a multidisciplinary decision, because you have to almost certain, 100% certain that there's no bacterial sepsis going on. Therefore, procalcitonin is invariably important to exclude a bacterial infection because IL-6 is a pro-cytokine. It's a pro-cytokine. It's not a cytokine per se. It's a pro-cytokine which causing your acute phase reactions. So therefore, IL-6 is the one which is causing elevation of CRP. So if you blunt IL-6, if there's sepsis, there's a high risk of mortality. So therefore, you have to prevent tocilizumab in bacterial infection. And not only tocilizumab, but there are certain trials has been shown that baricitinib, that is a JAK inhibitor, which can be used at this high hyperinflammation state. So that is not commonly used in Sri Lanka. It is not available as well, and there's no evidence to combine tocilizumab as well as this JAK2 inhibitors. So therefore, this decision about biological therapy has to be taken very carefully with all the investigations in background. The next stage is the invasive mechanical ventilation. We don't have ECMO frequently. We have only one machine in Karapide. But here, our aim is to prevent mortality at any cost. Again, now we are talking about hyperinflammation, but now we are talking about the late phase hyperinflammation or host response. So remember that whatever the most important step or stage in managing COVID is early stage 3 or stage 2. Because once your host response has causing the damage to the lung or whatever the organ, there's no recovery. So if the patients are intubated at the late stage and there's no recovery at all. And even though if they recover, there's a high risk of permanent or persistent organ damage. So usually, if the patients are intubated, their prognosis is usually low. And if you consider therapies, we can consider dexamethasone 6 milligram IV for 10 days or until the patient is discharged. And if the patient's admission, intubation, I mean, within 24 hours intubation, if the patient has elevated CRP levels without any of infection, at that point, there's a place for tocilizumab. But if it is more than 24 hours of intubation, there's usually no point of giving tocilizumab. So remember, usually we are talking about a window of 7 to 12 days or 7 to 14 days window to consider this biological therapy. If you delay that therapy or beyond that, usually their prognosis is poor. And again, the coagulation screening all the same. If the patient is having any evidence of thrombosis, you have to consider therapeutic dose of anticoagulation, but otherwise this patient should be on kind of antithrombotic prophylaxis therapies. Right. If I just summarize what is the scenario that we are practicing, and this is the kind of algorithm. If the patient is hypoxic and if the patient's oxygen requirement is going up, it is important to arrange a chest X-ray urgently. Why? Because there's a risk of pneumothorax as well as pneumomediastinum. Again, this COVID has been shown that it is associated with high risk of pneumothorax as well as pneumomediastinum. Therefore, your first step is to exclude a pneumothorax. So therefore, your imaging at high dependency or your ICU or in your kind of ward setup is very important in patients with COVID. And then if the imaging does not show any evidence of pneumothorax, if there are evidence of bilateral consolidations of the lung, then you have to do the CRP, the C-reactive protein. And along with that, you are usually doing a full blood count. You can see with the full blood count shows lymphopenia, neutrophil lymphocyte ratio is more than 10. You know, this patient, even though there are shadowing, this patient is in phase 2 now. And if the CRP is high, more than 75, now we know that this patient is at the late stage 2, where the host inflammation has started, right? So this is the stage that you should do a PCT at this stage. If CRP is rising more than 75 or it is doubling within 24 hours, and if PCT is no, if you have to do a PCT, and if the PCT is normal, now we know the patient is entering to the stage of the disease. That is hyperimmune state. That is the stage where you have to treat with tocilizumab in addition to the dexamethasone. And then if the patient's PCT is high, in that case, you have to strengthen the antibiotics. But what I see in a practical experience, most of the COVID patients, when they come to the hospital, they have been loaded with antibiotics. So evidence says within first 5 days, 5 to 7 days, starting of antibiotics is adversely affecting the outcome, because the viremic phase, when there's no evidence of bacterial infection, you are giving by giving antibiotics, you are strengthening of antibiotics. So you are blunting the antibiotic response. So therefore, you have to decide on antibiotics whenever you feel empirically there's a possible bacterial infection, but you should not at least use antibiotics when the patients are at the viremic phase or stage 1 when they are mildly symptomatic. Right, and again, antibiotic choice. I think I have seen some clinicians, they are considering starting meropenem and levofloxacin. These are really harmful because these patients are staying. Average stay of a patient with COVID pneumonia is 21 days. So when they are staying in a hospital for 21 days, definitely they are going to acquire hospital pathogens. So please remember that if a patient is recovering from COVID, they usually take about 3 weeks minimum to recover. So if you're using your multi-drug resistant antibiotics at the onset of the disease,